Dr. Kablin, so if we start by talking about rapamycin, because I think that that is a intervention that you work with a lot. There was a paper that you recently published, or at least you were an author on, which was related to people using rapamycin in an off-label way with, I
Right.
believe, with their doctor, right? Their doctor had to be involved in that. Could you talk a little bit about that paper? I mean, what kind of results did you see? What kind of dose was most people using?
Sure. Yeah. So just to set the stage, the study was designed really to collect data from, as you said, individuals who have been using rapamycin, what's called off-label, and really what that means is that rapamycin has been approved by the United States Food and Drug Administration for certain indications, like use in organ transplant patients, use in cardiac stents, certain forms of cancer, a few rare genetic diseases. And off-label simply, and those are the label uses of rapamycin. Off-label simply means the use of an approved drug for any other use that is not what it's approved for. And that's legal in the United States and in many other countries around the world with the prescription of a licensed medical provider. Now, I go through that because what you said isn't quite correct
Yeah.
in the sense that we did not require that the people who participated in our study were using rapamycin under the guidance of a physician. And we didn't do that for a couple of reasons. One is we didn't have any way to validate that. It would have required some complications with medical privacy for people to prove that they had a prescription on our end. And second, we really wanted to understand what was happening out there in the real world. And we certainly knew that some people are in fact using rapamycin and other pharmaceutical medications without the prescription of a doctor. That's just the reality of the situation. So we collected data from all of those individuals. We did ask them whether they were using rapamycin under the guidance of a physician, and the vast majority of the people who completed our study answered that they were. That's the other piece I want to just mention up front is one of the limitations to this study is it's all patient reported, right, or participant reported. So all of the data we collected is really coming from what they tell us. We didn't go back and laboratory confirm any of the information or require that people submit medical records, things like that. So this is a survey-based study of participant reported outcomes. Now, the way this was designed is it wasn't limited to only people who were using rapamycin off-label. We also collected data from people who had never used rapamycin. So we really ended up with two groups of individuals. We had, I think, 333 people who had previously used rapamycin, and then it was 100 and something. I should remember. I don't remember off the top of my head, but it was more than 100 people who had never used rapamycin. And so we kind of grouped people into those groups of rapamycin users and rapamycin non-users, and asked them a whole bunch of questions about their experiences taking rapamycin, including side effects that they may have experienced and their perceptions of the drug, lots of demographic information. And then we also did a little bit of a deeper dive on COVID-19 outcomes.
Right. And kind of what did you see? Did you see any differences between those taking rapamycin and those not?
Yeah. So the things that I could point to, I think there were really two primary things that came out of this study that I feel pretty confident about. Again, given the limitations of the study, right, you have to be a little bit cautious in how you interpret the data. One of the main things we were hoping to understand is whether or not in people using rapamycin off-label, there is a significantly higher prevalence of potential side effects that we might expect to see in people using rapamycin based on data from organ transplant patients, because that's by large the largest group of patients where rapamycin has been used in a clinical setting. And so we had a list of about, I think, 40 potential side effects. And the question was framed in the way where we asked, in the last 3 months, have you experienced this particular side effect? So that included things like gastrointestinal upset, various pain in various parts of the body, mouth sores. And there were, like I said, there were about 40 of these things. And the two groups that we compared were people who had never used rapamycin or people who had been using rapamycin for at least that last 3-month period. So they had to have been using rapamycin for that entire period. And the interesting thing there was only one potential side effect that was statistically significantly higher in the people using rapamycin versus the non-users, and that was mouth sores. And that makes sense. And in some ways, that was reassuring because that is by far the most common side effect that organ transplant patients experience. And so that was the thing we anticipated that should come out of this study, and it did. And it was about, I think it was about 15% of the rapamycin users that reported having had these canker sores in the last 3 months. And that actually matches up very well with what has been seen in prior studies with rapamycin or a rapamycin derivative called everolimus at comparable doses over about the same time period. So it was actually really quite reassuring to see that. Nothing else was overrepresented in the rapamycin users group. The other thing that was interesting about that was there were 6 other, potential side effects that were actually less frequent in the rapamycin users, statistically significantly less frequent in the rapamycin users compared to the non-users. Now that I want to be a little bit more cautious about interpreting too strongly, but they're potentially interesting. Some things like pain in the stomach or gastrointestinal upset, which was surprising because we expected, if anything, that would be higher in the rapamycin users. And then some things that I think are pretty interesting and worthy of additional study, like anxiety and depression. And the reason why I say that that's interesting is there's accumulating data for conditions like autism or other evidence that rapamycin does in fact impact brain chemistry. In fact, there's this whole burgeoning, it's very small, but growing area of research on rapamycin in combination with ketamine for things like chronic pain or chronic depression. So it's clear that rapamycin and then the protein that rapamycin inhibits, which is mTOR, impact the brain in ways that we don't understand. And so it wouldn't surprise me if those effects are actually real. But again, it requires more research. But I thought that was interesting that came out, that anxiety and depression were significantly, again, self-reported, significantly lower in the rapamycin user group compared to the non-user group. So that was one piece from the study that we learned. The other piece that was pretty interesting had to do with COVID-19. And I won't take you through the entire story other than to say that among the rapamycin users, if you think about a COVID-19 infection, we asked everybody, did you experience a COVID-19 infection? There was no difference between non-users and users in frequency of COVID-19 infection. So no evidence that rapamycin use affects risk of an infection with COVID-19 overall. What was interesting was the people who had used rapamycin continuously before, during, and after their COVID-19 infection were statistically significantly less likely to have experienced a moderate or severe infection as opposed to a mild infection, and significantly less likely to have self-reported ongoing symptoms, which we would consider consistent with long COVID. So again, suggestive maybe that rapamycin use in that context is protective against more severe infections and persistence of symptoms of COVID-19. And again, that requires obviously a more research and double-blind placebo-controlled clinical trials to really feel confident about, but there's reason to believe it kind of makes sense with the way that rapamycin works. In fact, there have been a few papers that have been published suggesting that rapamycin might actually be useful in the context of the COVID-19 inflammatory response and cytokine storm. And I would say our data are consistent with that. Although, again, you really want to see the double-blind placebo-controlled clinical trials to nail that down for sure. So I thought that was pretty interesting.
I mean, I don't suppose you can comment on whether it would work kind of post hoc on long COVID.
So I can't comment in the sense that I don't have any data. I can speculate, right. And I have speculated that in fact, yes, I think there's a pretty good chance that rapamycin would be beneficial in some people, at least with long COVID. And I guess that's the other piece I would say from our study. I think we can say with some growing degree of confidence that at least short-term use of rapamycin in the dose ranges that are typically used off-label is pretty safe. There's no real evidence for side effects, at least over a period of several months. Now, again, who knows? if you were to take rapamycin off label for many years, maybe there would uncover some side effects that we haven't seen. But I think I think we can be pretty confident that the risk associated with low dose use of rapamycin, at least in the short term, is pretty low. And certainly our studies suggest that. And so, yeah, I think that there is a pretty good rationale for testing whether rapamycin in people who have long COVID can help alleviate some of those symptoms. And again, based on what I know, I would suggest that you probably would see effects within about a 3 to 6 month time period. So it doesn't require a long time to actually do some of these studies to find out. And I think there's an opportunity to maybe help a lot of people who, really are still struggling, sadly, still struggling, with just their daily lives because they've got these ongoing symptoms.
So you mentioned dose. With what dose was most common?
Yeah, so the most common dose was 6 milligrams once a week orally. But I will say there was quite a big distribution. So, I think at the high end, there were 1 or 2 people who were up around 20 milligrams once a week. There were quite a few people who were doing, 1 to 2 milligrams once a week. There were certainly some people who were doing daily dosing with rapamycin. So there was a pretty big spread in the doses that people were using. But clearly the most common dose was right around 5 or 6 milligrams once a week.
If there's one mineral you should be worried about not getting enough of, it is magnesium. Magnesium is the body's master mineral, powering over 600 critical reactions, including hormone balance, stress management, sleep quality. Even digestion is influenced by the presence of magnesium. But there are 2 big problems here. The magnesium in the soil has been drastically reduced since the 1950s and is also removed by food processing, which explains why it's estimated that up to 75% of the population may be deficient. And most supplements contain only 1 or 2 forms of magnesium when our body needs 7. The only magnesium supplement on the market that has the full spectrum of all 7 forms is Magnesium Breakthrough by BiOptimizers. BiOptimizers are offering an exclusive deal for my audience, and it's for a limited time while stocks last. Right now, you can get a bottle of Magnesium Breakthrough for free. Just go to magbreakthrough.com/modern free. Thank you for your support.
Who can take rapamycin? You would never give rapamycin to a pregnant woman because pregnancy is a time of rapid growth. And if you block mTOR, you're interfering with growth processes. So pregnant women should never be taking rapamycin. You'd never give it to a child or a teenager, and I don't recommend it for young adults because they're still going through a rapid growth phase. But once people get to 30, 40, 50 years old, then they can start considering rapamycin, and we don't know what the optimum age is to start this drug yet. And I think probably it's different for different people. If you've got somebody that has health problems at age 30, might be good for them to start rapamycin, and somebody that's healthier, maybe a little bit later. We just don't know the answers to these questions yet, but I think people in their 50s and 60s should all be considering rapamycin because the health benefits are significant and the side effects are very, very minimal. A couple of the side effects that do occur occasionally. Some people might get low iron levels or low hemoglobin levels. Triglycerides and cholesterol might undergo some modifications. Some people, in fact, one of the most common things, some people will get an aphthous ulcer, a little mouth ulcer, kind of painful, but they usually go away in 3 to 4 days and they don't occur in most people. So most of the side effects that can occur are very minimal and they're easily manageable. But I encourage people to emphasize that this should not be taken daily. This is episodic use. 1 dose per week is where you get the maximum health benefits. And I'm also really encouraging people to do what's called the sirolimus blood test. And the drug name is rapamycin. The generic name is sirolimus, SIROLIMUS. And LabCorp has a sirolimus blood test available. You can go through the Life Extension Foundation and order the sirolimus blood test for $95. They have doctors on staff that authorize this. I then learned that the same lab test is available through LabCorp for $59 if your own physician writes the prescription. So I talked to my physician. She supports my use of this. She wrote a prescription for me that says standing order for the sirolimus blood test. So I can now, for a year, go on the LabCorp website and schedule a blood test for sirolimus whenever I want. And I'm currently trying several different manufacturers and testing my blood levels to ensure that they're getting good absorptions. And I took sirolimus rapamycin for a couple of years before I started doing the blood tests. And my initial blood test showed that my plasma levels were lower than I expected, around 2 nanograms per milliliter. So I have now upped my dose from 6 milligrams to 10 milligrams per week. And now my blood levels are up in the range of 5 to 7 nanograms per milliliter, which is the appropriate level to be at. But with this knowledge and my own personal experience, I'm now telling people, I think it's a good idea for everybody to test, because if you don't test, you don't know. So I think that everybody should at least do the sirolimus blood test once or twice to make sure that the dose that they're taking is giving them the plasma levels that's appropriate. And I also, last time I went to LabCorp, the check-in procedure first asked me for my identification. You put it in the machine, it takes a picture of it, and they ask you to turn it over, and they take a picture of the backside. Then it asked me to put in my insurance card. So I put in my Medicare card, and it took a picture of that. And it asked for my secondary insurance, and it took a picture of that. And I got my blood draw, and it was paid for by my insurance. So people can get, it's an FDA-approved drug. So you can get this sirolimus blood test covered on your insurance. So I encourage people to at least once or twice do the testing and make sure that you're getting appropriate plasma levels. And this is also a good way to find out that some generic manufacturers might not be good products. I mean, there's a dozen or so different manufacturers of generic rapamycin. And so you want to make sure that the brand you're taking is giving you appropriate blood levels.
There's definitely some things I would like to go back to in there. But
Sure.
so taking it intermittently, right? So
yeah,
partly kind of why do you need to take it intermittently? Kind of what's the mechanism behind that that's causing that? But also maybe let's do that first.
Sure. Well, you take it intermittently because when people take it daily, you get significant suppression of the immune system. And we don't want to go that far. We just want to suppress it episodically, which will slow it down enough to allow autophagy to be activated. So that's the explanation there. With episodic use, you get a partial inhibition of mTOR. If you take it daily, you get a major inhibition of mTOR, and that will cause significant suppression of your immune system. And we don't want to go there for healthy people.
Right. So the other thing, so you were measuring, using the sirolimus, you're measuring the blood levels in your serum of rapamycin.
Yes.
So I thought it would get cleared. And if you're only taking it like once a week, that it would get cleared. And so that like it would be there, suppress mTOR, and then it would go away for the rest of the week. But that's not what's happening.
There is a peak, and then it starts to go down. But during the peak and the first phase, when the plasma level is relatively high, it's crossing cellular membranes and going inside the cells and inhibiting mTOR.
Interesting. Okay. But then there is like a residual level always there.
Yeah.
Can you just say what would be a good target for that residual level?
The residual level for example, at the end of after your 7-day dosage,
yeah,
down to about 0.5. It gets down very low
right
at the end of your 7-day period.
We're aiming 6 milligrams per week, roughly. How do you know? I mean, if you're maybe a lady and you're lighter, or how do you know if you're having too much? What kind of metric could you look for?
That's why I encourage everybody to do a lab panel before they get started, to check things like iron levels, hemoglobin levels, all your cholesterol markers and so forth. And then after you've been taking it for a couple of months, I think people should get a follow-up blood test. But the main thing to track and be aware of is, how do you feel? How's your energy level? Are you feeling tired or not? And because it can also influence insulin levels. And so if you have hyperinsulinemia and the low blood sugar, you could get tired and listless and so forth. But so that I've outlined all these things in my book, the things that people should look for and the lab tests that I recommend that people get. So they'll have all this information. But I think everybody should do lab testing to make sure that their blood levels of hemoglobin and iron and cholesterol levels are all within normal ranges and not changing too much. If people take too high a dose, these things can get out of range, and anything can be abused. So, I mean, drugs like Tylenol, acetaminophen, and ibuprofen, people can get into a lot of trouble with these easily available over-the-counter drugs if they're not used correctly. So I think that rapamycin is very safe when it's taken once a week, and the rapamycin.news forum is going to be a resource for an enormous amount of people taking rapamycin and putting their information in, so we get more and more data to get more information about correct dosages and timing of dosages and so forth. Another thing I'll mention is that rapamycin is a fat-soluble drug, and we have difficulty absorbing fat-soluble substances. So a lot of people are suggesting you get better absorption with your rapamycin, that you take it with a meal that has fat in the meal. Fat will enhance the absorption. And grapefruit juice gets metabolized in the same pathway that rapamycin does. So if you drink grapefruit juice, you might slow down the metabolism of rapamycin and have higher blood levels, because rather than rapamycin getting metabolized and broken down, the grapefruit is actually a compound called naringenin, which is a phytochemical, and grapefruit juice goes through that same liver detoxification pathway. So people are playing around with this. We don't have all the answers yet. I think that we need to get a number of people that are testing what their plasma levels are when they take it without anything, and what their plasma level is when they take it with a fat-containing meal, and try it with grapefruit juice, and just see if these things make a difference. But this has been talked about on the forum, but we don't have enough information to really know all the answers yet.
Right. And that's a good thing, right? Because it just means that the rapamycin hangs around longer and is more effective. Yeah. What I'd like to talk about is rapamycin. And so how long did you say you've been taking rapamycin?
I've been taking it for over 5 years. As I started, I'd say 5.5 years. I started in January 2016. So I've been taking it 5.5 years.
Wow. Okay. And so can you talk about the dose and the schedule again? I mean, you did talk about the schedule. So we're trying to avoid activating mTOR2, right? Just activate mTOR1.
So we don't want to reduce mTOR2. We don't want to. mTOR2 is already. We don't want to deactivate mTOR2. We don't want to reduce it.
Right.
So I never use it any more frequently than once a week. So I might, depending on the different people and what's involved, I might use any dose, starting at 1 milligram to a usual more typical dose of 6 milligrams. But I might use any dose, but whatever dose I use, it's once a week. It's always just once a week. Although recently I've been taking it myself every other week, but I double the dose. So I double the dose and I take it every other week, because I'm taking the Dosage every other week, and I don't want to take them each at the same week. So one weekend I take the rapamycin, and one weekend I take the Dosage. So that is basically innovation that Scaloni came up with. He came up with the idea of using a real high dose, but then it should be used every other week. In other words, every other week is basically 5 half-lives. It's 65 hours. 5 half-lives is the theoretical 0 level before your new dose. So that's the idea of 5 half-lives. At once a week is 2.5 half-lives. Once a week, 2.5 half-lives, if you take a fairly low dose, gets you down to a very low dose, low blood level by the end of the week. But if you're taking a real high dose, seems to me you have to wait 2 weeks and have a full 5 half-lives to get down to a 0 level before your new dose. So that's the whole idea. You don't want to have a continuous, because rapamycin interferes with making mTOR2. How it does that is your body can't assemble. It can make all the little parts that make mTOR2, but it can't assemble them in the presence of a high dose of rapamycin, because rapamycin competes with the places that they go. It's like a competition. So that's why in transplant medicine, that's why they give it every day, because transplant medicine, they must knock out mTOR2 to interfere with the function of lymphocytes. They're trying to sort of like, and because in transplant medicine, they're using it as basically a biologic poison. They want to make the lymphocytes so deranged in their function that they will not recognize a foreign kidney as foreign. That's very messed up lymphocytes. But in order to do that, they need to maintain a continuous suppression of mTOR2. As soon as mTOR2 comes back online, right, if the transplant patients stop taking rapamycin for like 2 weeks, they would immediately reject the kidney. Probably just like 1 week would be enough that they stop for like 1 week, the mTOR2 would come back online, and it would become up to a functional level. The lymphocytes would become back and functional. They would look around and say, well, what's this foreign kidney doing here? And it would be immediately rejected. So the transplant patients, they have to take rapamycin every day for the rest of their life. So they're in trouble, because if they have any side effects, they can't stop. Well, transplant, like anti-aging people, if they have a side effect, they just sort of like stop, so we can, like, it clears up.
What dose would you start people on, or is it weight dependent?
I don't think it's weight dependent. I start slow. I mean, 1 or 2 milligrams, and then just stick with that, and then just slowly creep up. It's something you're going to be taking for a long period of time. There's no rush. Again, unless you have a cardiomyopathy or you have some severe immune dysfunction that you think it's going to affect in an acute pathology or something that you're really suffering with. But if you're doing this for the long haul, be the turtle, don't be the hare, right? be the turtle and be nice and consistent. Not only are you going to avoid problems, but you'll start to have greater insight. And I'll use me, for example. I hadn't taken rapamycin, was well knowledgeable in it, but when I got involved with this telehealth company, I thought, maybe I need to experience myself. I had experience with a number of people dosing it to it, but it's something that I was doing a bunch of other things. So I'm like, it would just muddy the waters on, the signal on some of these other therapies. So I said, all right, I'm going to take it. My wife had good response with it. And I literally started 1 milligram every 2 weeks, and I worked up to 4. And about 3, I think I took 4, and I had a hives on, or like a little urticaria on my neck. I really didn't think anything of it. I thought it was something else, so I ignored it. And the next time I took 4, 3 days later, I woke up, and if anyone ever wore braces, it felt like I just got braces on, and the orthodontist just tightened them 2 times too tight. Just my teeth and gum were just really painful. And I have a pretty high pain tolerance, and for 2 nights it was like I just didn't sleep well at all. It was because it was that painful, and it's like, and it was just 4 every 2 weeks, and it wasn't an aphthous ulcer. that people work through, which is unclear. It was just really sore gums, and I'm not quite clear what that response was and why. I might revisit or go back, but I stopped. I was like, okay, maybe I don't need it. Maybe I'm just metabolically, because I do a lot of the other things I was pushing, and it could drive something to do with. I'm only postulating. One of the ways that rapamycin works is mitochondrial function. It also affects iron and copper. And it could be I drove this heme oxygenase pathway to produce more carbon monoxide, which is inflammatory. I also have been donating blood for a bunch of years, so my iron levels are low. I take copper. So I could have been an outlier in this. So the point is, perhaps I don't need it, right? It was something, I'm fit, I have good muscle, I'm lean visceral fat. Why am I taking it? And even if you look at the mouse studies, it's like, look at the curves. It's like it moves them 10%. And it's like, all right, the mice can't intervene to be metabolically healthy to begin with, and mice die of cancer. So I'm not sure. Maybe it's just not something that's appropriate for me at this point. Maybe in 20 years. But then on the other hand, in 20 years, we better have something a lot better than just rapamycin.